Yeah. Uh, Good afternoon, everybody. Welcome to the February CTIPP Can Call. I'm Dan Press. I'm the General Counsel for CTIPP, and co-hosting with me is Jesse Kohler, the Executive Director of CTIPP. And we're really pleased to have you join us today. I realize that this is in between Lincoln's birthday and Washington's birthday, and we celebrate two really courageous leaders. And I was thinking about all the people who are on these calls who are courageous leaders in their own communities, in their own states, who are implementing trauma-informed programs, breaking new ground, saving lives, saving money. So I just wanted to thank you and acknowledge you at the same time we acknowledge those two great leaders. We have two terrific presenters focusing on an issue that too often gets overlooked when we talk about trauma-informed programs, and that's prevention. How do we prevent the next generation from becoming trauma-informed? We have two different organizations that are deeply into that issue, and we look forward to their presentations. Jesse will be introducing them more specifically when we have that time to come. In terms of updates, there are two Hill updates I wanted to share with you. One, Senator Murray, who chairs not only the Health, Education, Labor, Pension Committee in the Senate, but also the Subcommittee on Appropriations for Education, Labor, Health, and Human Resources, had a hearing on the high rate of suicide among youth since the pandemic began. And she is looking forward to doing some appropriating to put money into the federal budget in FY23 to address youth suicide. CTIPP's going to be submitting testimony saying that if you want to address youth suicide, you need to address trauma. But I encourage all of you, if any of you are running programs, trauma-informed programs to address youth suicide, please share that with us. We'd like to share that information with Senator Murray and the committee and use it to support the argument that the best use of new appropriations, if you want to reduce youth suicide, is through trauma-informed programs. So that's number one, and we'll keep you posted on that. Secondly, something that a bunch of you old timers probably are familiar with, and coming back, is the idea of earmarks, where a specific congressperson or senator can put an item into the appropriations bills to help a specific program. And it got overused back in the late 90s, and Congress eliminated it. Now it's coming back in a very modified form. Eligibility is only open to local governments or nonprofit organizations, and the programs are limited to certain departments. Each congressperson gets to submit a list of proposed earmarks to the Appropriations Committee, and then the Appropriations Committee will sort through it and probably pick one or two for each congressperson. It's a great opportunity to get funding without having to go for a federal grant. It's also a cumbersome process. If you have a program you think would qualify, we recommend you get in touch with your congressperson's office. The Senate will eventually be also doing earmarks, but the House that starts the process. So right now, the chances are your congressman either has something on his or her website, some form of application like the one Jesse is flipping through, asking information about the project, or they're going to be doing it soon. But to be most persuasive and effective, get a hold of your congressperson, find out who in that office is responsible for the earmarking process. Get to know them, let them know about the great work you're doing, build up their support, and then have them help you fill out the application. There's some questions in there about which appropriations line item you're seeking to attach. And that's something you really need to get information from the staffers. That's not something that's easily available. So you really need to work with your congressperson, but the range of earmark funding is anywhere from $500,000 to $2 million. So we're talking real dollars, and take advantage of it. So many of your programs are so compelling and so effective. It seems to me you can make a really strong case for an earmark. And it's also a great way to educate your congressperson's office about the work you're doing. Will have ramifications way beyond just the earmark process. So go after the money, and hopefully at least some of you will be able to report back in 6 months and say, yeah, I got $500,000 or I got $1 million through this earmarking process. So that's the word from Washington. We had high hopes that the Build Back Better bill was going to include $2.5 billion for trauma-informed local coalitions. Unfortunately, as you know from following the news, that the bill got killed by Senator Manchin. So at this point, there's no effort underway, no plans to try and have that 2.5 billion be enacted through any other piece of legislation. So we're back at our where we were, which is going to have to fight over the coming years for funding for local trauma-informed coalitions. And that's going to be one of CTIPP's highest priorities. And one of the vehicles we're creating to make that happen in a partnership with PACES Connection and the National Prevention Science Coalition is an organization we're calling a Coalition of Local Coalitions, COC, an organization that will lobby Congress for appropriations and for other legislation to promote trauma-informed programs. By having a grassroots network of local coalitions, it will have a lot of influence, a lot of power on the Hill. The three organizations I mentioned, excuse me, will do the lobby and will walk the halls of Congress. The local coalition will lobby their own individual senators and Congress people, and there'll be a lot of information sharing back and forth. We encourage, there's no fees for dues or anything else for joining the COC. We encourage you to join it by going on to the PACES Connection website. Jesse, are you going to put that in the chat box? Jesse will show how to sign up for it. There are something like 250 local coalitions and then a bunch more state coalitions. And we're hoping we can have hundreds that are members of COC. So it becomes a powerful force in Washington. In my experience, the way you influence Congress is a squeeze. You have people walking the halls of Congress talking to the staffers here. And then you have people at the community level talking to their congressman from the community point of view, the second of the voters, and they really have the most clout. But they also share their clout with the people walking the halls of Congress. So it's a dual effort. It can only work if both sides are doing their job. The three organizations are committed to, at the national level, to becoming a lobbying force or an advocacy force in Washington, and we need you at the local level to do the same. So please sign up for the COC, and we're going to try and find a better name for it, but right now it's the Coalition of Local Trauma-Informed Coalitions. And we want to be a powerful force that right now there's so much great trauma-informed work going on around the country, but it's being done in isolation. Each one is creating a little ripple. What we need to do is combine those ripples into a current that will eventually wash over Washington and cause Congress to put the kinds of funding that we all know we need into their budgets. So with that, I want to turn it over to Jesse to introduce our speakers and to talk about whatever else you want to talk about.
Well, the other thing that I was going to cover, Dan, very quickly was just a
Yeah.
reminder that we are having these workshop series. So in the chat, I just put 3 links. The first one is that PACE's connection page, Building a Movement, that Dan was referring to, where folks can go join that community. I also put the join the trauma campaign site to join the trauma campaign as an individual or an organization. And the last one is that workshop series sign up form. So you can go there, join for free. Our next one is going to be this Friday. We're going to have a workshop on transformative justice. And then we're going to have a panel on faith-based communities that are doing trauma-informed work. And it should just be an absolutely fantastic session. The last 3 have been great. We are seeing that community continue to spread. We have over 2,500 people signed up. We want to invite you all to share this with your network as well. As a free resource, we are putting that resource center together from everything that's been shared, and the recordings are also available. We recognize that 4 hours is a long time, and we are working to shorten those moving forward. And so there will be more to come on that. The last thing that I'll share very quickly is that we do have another and better name for the COC. It's Press On, which I've been trying to get Dan to say, and he won't because he is very humble and doesn't want it, but I think that it's a catchy name. And so just so folks know, if you hear Press On in the space of what Dan just described, that's why. But Dan, you don't have to say that. I'll say that for you. And so with that, again, we have 2 wonderful panel presentations today, rather. One from Jenny Wing Harper from the Nurse Family Partnership, and the other one from Kelly Murphy at Families USA. We're really going to be focused on MIECHV, which is the Maternal, Infant, and Early Childhood Home Visiting Program, which is up for reauthorization this year. We'll start with Jenny, who is the Director of Federal Government Affairs for the National Service Office for Nurse Family Partnership and Child First. In that role, she leads the development and implementation of federal legislative and regulatory strategies to support funding and public policy for 2 evidence-based home visiting models. She also serves on the steering committee for the National Home Visiting Coalition. So Jenny, without further ado, I turn it over to you.
Great. Thanks, Jesse. Thanks, everyone, for having me. Let me see if I can share my screen here. And can you guys see?
Looks great.
Okay, great. All right. So I'm going to talk a little bit about home visiting first. I know that some of you may be very familiar with it, but just so that we have a chance to lay out kind of broadly what home visiting is, and then talk a bit about some of the specific home visiting models that I work for, and then get into MIECHV reauthorization. So let's see. Okay. Did that move on to the second slide? I can only see you guys.
Yeah, it's moving on.
Okay, great. So home visiting programs are programs that are generally meeting in the home or meeting families where they're at, and they're providing structured visits by trained professionals and paraprofessionals to families that are impacted by social and economic inequality. And they're meeting families either in pregnancy or in the very first years of a child's life. And so these programs support families by providing everything from health checkups and screenings, referrals, parenting advice, guidance with navigating, services in the community. They also are really important in monitoring children's development and milestones, and ensuring that children have a safe, stable environment to grow up in. And so home visitors are working with these families for a sustained relationship over many years, and building a trusting relationship with that family. So this slide just talks about a bit of the the different types of services that home visitors are providing. So there are lots of home visiting models across the country that operate for, very targeted communities or very broad communities. Nurse Family Partnership, which is, one of the larger home visiting models and has one of the larger footprints of home visiting across the country, is a home visiting model that utilizes registered nurses. And we have a very specific model that begins implementation during the pregnancy, prior to 28 weeks of pregnancy. And then it works with that, with that mom up through the first 2 years of the child's life, either the mom or the family or caregivers who are part of that family. And we generally deal with first pregnancies or first time moms. And the goals there are really to improve pregnancy outcomes, to improve child health and development, improve family economic self-sufficiency. And so what we're doing is having that nurse begin meeting with the mom, making sure they're getting all of their proper prenatal care, dealing with issues that, may be present, such as a substance use disorder. And then, through the first couple of years of the child's life, focused on everything from, safe sleep environments to breastfeeding, to making sure kids are getting their well visits, dealing with, other referrals that may be necessary to other providers, ensuring if there's other services the family needs, making sure they're enrolled in SNAP or WIC or whatever, whatever's required for that family. And then also really helping that parent set goals for themselves, whether that's, finishing high school or getting a GED or going on to college. And so we have a really strong research base of multiple randomized controlled trials over 40 years that have shown, really strong outcomes in terms of, healthier birth weight babies, reduced NICU stays, reduced ER visits in the first, few years of the child's life, better school readiness, better family income earnings over time. And NFP right now operates in 40 states and serves about 38,000 families. And then last year, NFP merged with another home visiting model, Child First. And so that's why we are now the mouthful of the National Service Office for Nurse Family Partnership and Child First. But Child First is also a home visiting model, and it's different than NFP in that it works with a master's level mental health clinician and then a bachelor's level care coordinator. So they're preparing two professionals with the family, either prenatally or at the birth of the child up to the 5th year of the child's life. And they're really focused more on mental and behavioral issues, and really working with families that are facing a number of challenges. And so they're really working on, connecting families to, needed services in order to address stress in the family's life, and then building those really strong, parent-child relationships that are, focused on protecting and healing the brain from trauma and stress. And so Child First is a much smaller model in the sense of our footprint. We are in 4 states right now, but part of the goal of the merger of these two organizations was that we can, begin to implement Child First in many more states across the country. So the main sources of federal funding for home visiting right now are the Maternal Infant Early Childhood Home Visiting Program, or MIECHV, as Jesse said, and then Medicaid reimbursement, which you'll hear a bit more about from Kelly, and then the Family First Prevention Services Act, which passed in 2018, which allows states to redirect Title IV dollars from foster care placements to evidence-based preventative services. So, we work on braiding all those funding streams together, accessing those funding streams in different ways across different states to increase the services we're able to provide. But MIECHV continues to be the largest single source of federal funding that we have for home visiting services. So let's get into MIECHV a little bit. It was created as part of the Affordable Care Act, and it's Title V of the Social Security Act. These are formula grants to states that states, territories, and tribal organizations. And what it does is the funding goes to states, do a needs assessment, and then states are allowed to select from a sort of clearinghouse of evidence-based home visiting models, of which there's 19 currently. They can decide which home visiting model meets the needs of, their community the most, or different communities across the country. Oftentimes you'll see states, have 3 or 4 or more different home visiting models operating within them. So, there's strengths of each different type of home visiting model. And for example, Nurse Family Partnership serves first-time moms only beginning in pregnancy right now. So that sometimes limits the population that we can serve. we are looking at expanding that and rolling out kind of another service within our NFP, but that's just sort of the types of criteria that states might be looking at as they're looking at how they want to serve families across their state. So at the federal level, the program's administered jointly by HRSA and the Administration for Children and Families. A few interesting things about MIECHV is that it's really had a lot of bipartisan support, and it's really held up as like kind of a shining example of how evidence-based policy can be put together. And so states have to spend 75% of their funding at least on evidence-based programs. So there's like I said, there's this clearinghouse that's designated 19 different home visiting models as eligible for MIECHV funding, but then states can also do up to 25% of the funding on promising programs. So these are programs that have shown some impact on outcomes that are laid out. We'll talk about the benchmarks in a second. But they have sort of a certain amount of time to either move up in the evidentiary standard or discontinue funding. Because of the limited amount of MIECHV funding, not a lot of money really gets spent in that promising category, because states are generally investing in what they know, is eligible and will continue to be eligible moving forward. Let's see. So these are the benchmarks. MIECHV has very specific benchmarks that programs have to, so states have to identify how they'll address the needs outlined in the statewide needs assessment, and states have to meet or exceed established benchmarks in four of these benchmark areas. And then they have to, report on progress against these benchmarks. So you can see this is kind of, focused on child and newborn health, maternal and newborn health, school readiness, crime and domestic violence, family self-sufficiency, coordination with community resources. They've been realigned a few times. There's a number of other kind of sub-criteria that's been developed under them, but for the most part, these are the benchmarks, and I believe these are likely to remain the benchmarks for a while under MIECHV. And then as far as the funding goes, MIECHV is mandatory funding. So this is not subject to the annual appropriations process. And the program was last reauthorized in the Bipartisan Budget Act of 2018. So which was passed 4 years ago this month. But when that funding passed, our authorization had already lapsed. So that funding was retroactive to October of the previous year and takes us through the end of September this year. So we're funded at $400 million annually, which is essentially the flat funding of the program. Since its inception, the program was ramped up for the first couple of years. And since I think FY14, it's been funded level at $400 million annually. And as I said, it expires on September 30th of this year. And so without proactive action by Congress, that funding goes away. It's not something that can just end up on autopilot like other reauthorizations that we see Congress never quite get to. So it's a bit of a kind of do or die situation for the home visiting community, and we're really focused on MIECHV reauthorization this year. As I said, it was created as part of the ACA, and there were several short-term reauthorizations that occurred in 2014 and 2015, and then the last reauthorization that occurred in 2018. So it's kind of been a while for MIECHV. There's been a lack of activity on MIECHV on the Hill, just because we were given 5 years of funding, and there wasn't a lot to do in those other years to continue to get that funding. But now we're ramping up, trying to get policymakers focused on this, trying to make sure that action happens on that this year. So what are we asking for this year? The big thing is we're trying to get more money for the program for the first time ever. We are asking for an additional $200 million a year for each year of the reauthorization. So essentially ramping that funding up over 5 years from its current level, 400 million, so taking it to 600 million, 800, and then getting it to 1.4 billion by the 5th year of the reauthorization. That's a big ask. We're over tripling the funding, but I think there's a really strong case to be made that we have not had any increases in funding since the inception of the program, and that this is a program that has really rigorous evidence standards. It has really strong outcomes associated with it. There's really strong cost savings associated with evidence-based home visiting programs. And, there's bipartisan support for the program, which is unique these days. And so we really want to ensure that we are getting more funding so that we're serving more families across the country that benefit from these services. And also that we're addressing rising costs within programs as well. We're hearing workforce issues across all of the different home visiting models constantly. And it's something that, we know we want to address within reauthorization. And the best way we can do that is with additional resources going into the program. We also want to double the tribal set aside from 3% to 6%. Right now, 3% of the program, 3% of MIECHV dollars go into the tribal MIECHV program, which is separately administered from the regular MIECHV program. And we want to ensure that there's additional resources there as well. And then the last thing is we want to make permanent the telehealth and virtual home visiting that has been occurring since the pandemic. Prior to the pandemic, NFP had studied telehealth visits for home visiting, and it was something that we knew could meet our model fidelity and would allow us to have more flexibility with our home visiting workforce. And obviously, we all had to provide services, almost entirely virtually throughout parts of the pandemic and continue to do so in some places. And, it's not something where we want to provide home visiting services virtually entirely, but we know that a lot of the visits can be done that way. And we know that that does, support workforce, especially those that are operating in rural areas where they might have to drive an hour to visit a family, or where there's other, circumstances that come up that would otherwise cause a home visit to get canceled, but might be able to be done, over video teleconference instead. So this is something that we want to make sure we can continue moving forward, but we neither want to operate, fully virtually in terms of home visiting services, and nor do we want to see it as a cost reduction measure, because we know that's not really where you're going to save money on home visiting. And then in terms of what's going on in Congress, we don't have a lot of timing yet. I think that the Build Back Better Act and the lingering appropriation FY22 appropriations have really kept Congress from focusing any attention yet on MIECHV, and it's also early, in congressional world that it doesn't expire till September, so they've got lots of time to act on it. Last reauthorization, so in 2017, we had a hearing in Ways and Means, and there was a nurse family partnership nurse and young mom who came in to testify as part of that hearing. We're hopeful to see some sort of hearing again. We're beginning to have more productive conversations with authorizers. We are under the jurisdiction of the Ways and Means Committee in the Worker and Family Support Subcommittee, and also in the Senate Finance Committee. We imagine that there will be some sort of year-end health extenders package that we might end up on, and by year end, probably like calendar year end. So there's a strong likelihood that we might see a small lapse of the program from that September 30th deadline until something gets done, right before Christmas. And, we can live with that. We don't want to see that happen, but, I think the challenge, one of the main challenges for us is really that vehicle that the reauthorization can move on. It's not going to move as a standalone piece of legislation. Most likely, last time, as I said, it got passed on the big bipartisan Budget Act, which was a very sweeping piece of legislation that included a lot of programs. Prior to that, it had been a part of, several doc fix bills. So we're kind of floating out there on our own now and have to find some friends to move with legislatively. We have a lot of, strong champions of home visiting across Congress. Some of them who were there for our last reauthorizations are no longer there. Speaker Paul Ryan was a huge fan of MIECHV and of NFP in particular. And we also have, just an uphill battle of new member education that, a lot of members of Congress are new since, early 2018 when this last passed. And so we just have to spend a lot of time explaining what home visiting is, explaining what MIECHV is, explaining the different models, how we operate, why we need additional funding. I'm not that worried that the program won't get reauthorized in some form at some point. I am worried about when that point will be and if we're able to get any additional funding. I think that's really going to be the crux of what we're fighting for, is making that justification for additional money. I think we kind of like the home visiting community kind of talks about that everyone loves MIECHV and they love to show it off as this great, evidence-based program, but no one's really given us love in terms of additional funding. And so to get that, to maintain that bipartisan support and to also make the case for more money, that's our work that we have cut out for us. So I mentioned there's, this broad home visiting community. There is a National Home Visiting Coalition. There's a steering committee that I'm a part of that consists of a number of home visiting models. So Parents as Teachers, Healthy Families America, and HIPPY, which I cannot remember the acronym for that right now. Those, and then NFP and Child First. So we're the models that sit on the steering committee. And then you've got groups like the American Academy of Pediatrics, MIECHV, ASHV, which is the Association of State Home Tribal Home Visiting Initiatives, First Focus for Children, First 5 Years Fund, First 5 California, Start Early, and 0 to 3. Those are the groups that comprise the steering committee. We meet weekly. We hash out a lot of, policy discussions about, reauthorization changes that we want to see, where we're at. Also just, collectively sharing intel. I think, one sort of long ago lesson of the home visiting world is, as home visiting was becoming a federal program and the development of MIECHV as part of ACA, is that it was written to support all of the evidence-based models, and that we, even though our competitors, we come to this coalition as, true partners in trying to, get as much MIECHV funding as we can collectively. And so instead of, operating where we're talking to this congressional office about something and someone else is talking about something else, we hash out all of our policy fights as a coalition, and then we present a single set of recommendations to Congress. There's also a broader home visiting coalition beyond the steering committee that consists of, I think it's about 30 groups or so. Again, it hasn't been really active at all for the last few years, as there hasn't been as much to do. But we're bringing that group back together. So the full coalition meets monthly now. And then there's also a state and local subcommittee that's, full of affiliates, groups, advocates, other people, stakeholders that meet monthly as well, a separate monthly call to talk about kind of updates and opportunities for advocacy. And so on opportunities for advocacy, this is a big push this year where we really both need to get attention to the issue. And as I said, make the case for reauthorization with additional funding. We are in the process of circulating a national sign-on letter to be signed by both national as well as state and local groups. Signatures will be kind of divided up by the national groups and then state and local by state. I think we had around 700 or 800 groups sign on to that several years ago when we last did a national letter like that. And so we're hoping to do something similar. The deadline for that letter to sign on is February 25th. Although, with most sign-on letters, there's usually a little window after that where we continue to allow people to sign on. But that's something I can share with Jesse if people are interested in taking a look at that and seeing if their organizations would be interested in signing on to that letter. And, the letter just lays out basically the ask that I talked about here today, and will be sent up to Congress, and then that'll be used as kind of the marker of what we're really trying to achieve with this reauthorization. As I mentioned, we have these monthly calls with, stakeholder groups, other groups that are interested, to provide updates as well as provide, opportunities for advocacy there. We have not done any specific activations at this point, but we imagine that there's going to be, a series of alerts where we're trying to get people to, either email their members of Congress or tweet or do different activities around, whether we have a hearing or whether legislation is introduced or different points throughout the process. We will also be sending out some social media toolkits throughout the process. The coalition was fortunate to get some funding at the end of last year to support some communications work. So we have an outside communications firm that is, developing some content for us. We are just getting that process underway right now. So we don't have anything to share just yet, but we'll hopefully in the next month or so. But we have a Twitter feed that has just gotten reactivated. I should know the handle offhand, but it's the National Home Visiting Coalition. There's an old Twitter handle from a previous coalition that is not who we are anymore, but the coalition has been housed in different places over the years. We actually originally started out as a project of Pew, Pew Charitable Trust, where we, aren't anymore. But it's been an evolving process. And so, yeah, we're excited about, what lies ahead and the opportunities, to continue to grow support for the program, grow interest in it, and grow bipartisan support for the program, because, we've been told over and over, and we know that the program will not be reauthorized without bipartisan support. So in the past, our champions have been Senators Grassley and Menendez on the Senate side. And then on the House side, Congressman Danny Davis and Congresswoman Walorski, who chair and ranking on the Worker and Family Support Subcommittee, will be our main leads this year as well. So we're out hitting the halls of Congress and having all of our virtual Zoom calls and doing all the things now. And yeah, excited about it. So happy to be a resource to you all. If you guys have questions, how you can connect, please let me know. But that's all I've got for you right now.
Thanks so much, Jenny. We've got a few questions in the chat. I know that generally for CTIPP can calls, we've sort of saved questions for the end, but we'll have some questions here now before we get to you, Kelly. So first of all, does Nurse Family Partnership focus on early literacy training in homes, especially for parents who may not be literate themselves or are poorly literate?
That's a great question. We do not. There are other home visiting models who do more of that. I'm not sure. I don't know exactly what we do if we encounter a family that needs those supports. In general, we are doing, lots of different screenings and trying to connect family to services, even if we don't provide those services directly. We certainly do provide a lot of coaching and guidance around the importance of, reading to kids and bringing books into the home and doing that, having parents do that with the kids and talk about that and experience that. So yeah, that's kind of where we're at on that.
Gotcha. So more of like a warm handoff, maybe.
Mm-hmm. Yeah.
Kelly, this may even be a question for you if you know, but for either of you, is there a resource page or database that pulls all or some of the evidence for home visiting services?
All of it. So the HOMVEE, HOMVEE, is essentially like the clearinghouse that reviews all of the home visiting models for their evidence of effectiveness. And if you go to that, you can look at all of the thanks, Kelly. You can see the different models that have been approved, and you can click on each model and see the different evidence kind of base within there. That's not to say that's a comprehensive list. There's lots of other home visiting models that provide different types of services, but those are the MIECHV eligible ones.
Okay. For the monthly calls that you were discussing, we'll support the sign-on letter. We want to support through our campaign the reauthorization, so we'll definitely send that out. But if folks on the call want to join those monthly calls, is that an open call? Is there a way to sign up for those?
Yeah, there is. And I'll pull that together as well when I send you the letters if people want to sign up. I think we have like a sign up form somewhere. I'm not sure where it is exactly right now.
Gotcha. And then the last question, and then Kelly will get to you, and then we'll do the same thing of questions for you, Kelly, and then we'll have a broader community conversation. But Jenny, how do trauma-informed approaches fit into the Nurse Family Partnership and Child First model?
That's a great question. And I don't know that I'm going to be really the expert to give the answer on that. There's a lot around being able to address trauma, particularly in the Child First model. I'm still learning a lot about the Child First model. As their integration with NFP is relatively recent. And I have worked on MIECHV professionally for many years and all of the previous reauthorizations, but I actually just started my position with Nurse Family Partnership and Child First last summer. So the actual elements of the programs are still, there's a lot to learn. But with Nurse Family Partnership, we are generally doing screenings around mental health and connecting to services again that might be needed there. On the Child First model, it's a lot more directly around having that mental health clinician provide those services directly to the family as part of the home visiting.
Beautiful. Thank you. And however we can fit in and support that ongoing integration of trauma-informed supports, we're happy to do so. So a shameless plug there.
Absolutely. Thank you.
But thank you so much. And next we have Kelly Murphy, who's the Director of Early Childhood and Maternal Health at Families USA. Kelly is a maternal and child health policy expert who has focused her career on helping state and local governments solve some of the most pressing public health challenges of our day. At the National Governors Association, Murphy served as a program director where she developed, implemented, and led NGA's public health strategy, including policy priorities on maternal and infant mortality, early childhood development, the opioid crisis, public health preparedness, childhood obesity, vaccines, and other issues. Most recently, Murphy served as the project director for the state opioid response grant at the District of Columbia's Department of Behavioral Health. Kelly, I promise for every speaker in the future that I will type it out so that I don't refer to you by your last name while you are actively on the call, but looking forward to the presentation.
And actually, thank you. That gave me a minute to like figure out if I can screen share. So I appreciate the long introduction so I could pull up the right version of this presentation. Let me see if I can share this. I don't know why 2 years into a pandemic, I'm still figuring out how to screen share, but here we are. Hopefully you guys can see this. Yes. Sorry, I think that is everything frozen? Everything's frozen.
Yeah.
Yeah, everything is frozen, isn't it?
As it's
all
figuring
coast
itself
should
out.
be.
I think that I actually lost some skills somewhere along the lines in terms of so many Zoom calls. I've forgotten, like there was like a year of progress followed by a year of regress.
Oh my gosh, this is and of course it must freeze in this exact moment. Can we just appreciate right now, actually? I'm so sorry. I'm so sorry. Not my intention. Okay, wait, let's see. Okay, I'm no longer screen sharing. Is that accurate?
Yes.
You know, I have some like fun pictures in this. So I'm gonna try one more time. Hopefully it won't shut down the internet.
There we go.
I look like I'm moving. You guys can see this. That's a good sign. All right, let me put this in presentation mode. Okay, are we good? I'm not gonna touch anything else.
All set.
Thank you for bearing with me. I have a bunch of caveats. The first is that I'm not good with technology, obviously. The second is that I am recovering from a bad cold because I have 2 little ones at home that are germ pods. So if my voice goes in and out, please excuse me. The third is that I am not a Medicaid expert, but I am here pretending to be one. So I will answer any questions I can about Medicaid. Our work has intersected obviously a lot with Medicaid on this program. And then the fourth is that I did this presentation while watching the Olympics this weekend. So I added a little Olympic content in because why not? And tried to like give you guys a picture because the slides have lots of words. I think those are all my caveats. Thank you so much for having me. I am Kelly. I work at an organization called Families USA. Families USA is an organization that really focuses on the big picture of helping every American or every individual in this country achieve the best health and the best health care that they possibly can. We see ourselves really as a leading national voice for healthcare consumers to kind of achieve this ultimate goal of health in really whatever that means to whoever might be talking about it. So if you've never worked with Families USA or heard of us, that is who we are. And again, apologies for the cold. We work across a lot of different disciplines at Families. We have a partnerships arm. We have communications work that we do. We do a lot of campaigns. We have a lot of folks that work on our federal relations. And then I sit in our policy shop where we're trying to develop policy strategies to kind of achieve that overarching goal that I shared. And really quick, we work at the national level, we work at the state level, and we work at the local level. my experience with which Jesse just shared a lot has focused on the state level because I came from the National Governors Association. So my brain, maybe unlike Jenny's brain, who just spoke, goes to state policy levers always first. So that's why this project really speaks to me, because it's Medicaid, which is a huge state policy lever. I told you there were going to be Olympics. And if you all didn't see that Erin Jackson won the first gold medal of any Black individual in speed skating, it was incredible. Highly recommend, check out YouTube. Just like had to share a favorite Olympic moment because I was feeling the Olympic spirit when I was making these slides. So go Erin. Okay, so the importance of prenatal health. I feel like I probably don't need to say a lot of the stuff that is on these slides, and I'll probably move through them pretty quickly so we can get to the discussion. But you know, it's important to like center ourselves and remember that 700 women die as a result of pregnancy-related complications in the US every year that are largely preventable. And I love that Dan set up this conversation initially as this is a conversation about prevention, because it really is. Like these interventions, home-based home visiting, especially evidence-based visiting, you know, or evidence-based home visiting programs really are a preventative program that can be implemented and really improve outcomes. Jenny was just saying, right, that there's the data is there showing it. So women die, unfortunately, in childbirth or within a year after childbirth. And then also really, really importantly, and this has been on the front page of many newspapers for the last several years, that Black and Indigenous people really face a much greater risk of pregnancy-related death than white people. The outcomes there are just incredible disparities in health outcomes. And the other thing I want to highlight on this slide is just that perinatal health, which is the health of moms and babies before, during, and after birth, it's profoundly impacted, like it says, prior to conception, but it is not written in stone. It can be sort of improved throughout pregnancy, in between pregnancies. There are chances to really make an impact. And I think that's why some of these models are so important and so helpful, especially from a prevention perspective. So sharing some DC statistics for you. I want to make sure, I'm just gonna look ahead for a second. Okay, I'm sharing DC statistics because the work that this roadmap, which is what I'm really here to talk about, is a publication that Families USA put out very late last year to help home visiting services get paid for by Medicaid. And I'll talk a little bit more about that publication and what it lays out for states in a minute. But that was sort of born out of a project that Families USA is doing with Nurse Family Partnership and an FQHC in the District of Columbia to try to get Nurse Family Partnership home visiting services to women, children, families in Washington, D.C. So I present some DC data here just so you can see, again, I know everyone probably knows this, but it just is so important to remember that the incredible disparities that there are in the maternal health outcomes, which I just shared in general, but also infant outcomes, infant mortality, preterm births. So in the district, for example, the number of preterm births, or the amount of preterm births among non-Hispanic Black women, it's 60% of all of the births in the district. Of the preterm ones, 60% of those are to Black non-Hispanic women. Same with low birth weight. The infant mortality one, which is the third stat here, is, absolutely horrifying that the rate could be, 90% of the infant deaths are among non-Hispanic Black women. It's just, the disparities are huge. And if many of you may be in the district, or maybe many of you are out across the country, but wards 7 and 8 are sort of our most historically underserved wards in the district, and the wards that have the greatest majority of Black individuals in the city. So just sharing some DC statistics. So our project in Washington, D.C., I just mentioned this, it's working with an FQHC. The name of the FQHC is Mary Center, and we are working with them to bring NFP services into the district to really try to improve these outcomes, especially among first-time moms, especially among high-risk first-time moms, as the NFP model is made to do. Some interesting things is that we started this program, I think it started up in June, and we already have 38 participants that are doing NFP in the district, and we already have 5 babies that have been born, which is super exciting. So the program is already up and running. And the overarching goal of this work, more broadly, actually, the overarching goal is to get district's Medicaid program to cover NFP services. That's sort of our long-term, end of the day goal in DC. But the long-term goal is to try to help other states model what will happen, hopefully, in the district where the services will be covered, and spread this to other states. So spread and scale the model. I'm not sure how much everyone on here knows about Medicaid, but it's not going to probably surprise anyone. My bullet here that says Medicaid pays for some home visiting services in state, but it is not standardized. Like most not shocking thing probably ever said in a presentation, because when you know one Medicaid program, you know one Medicaid program, and that's really the talk about Medicaid. So there are some home visiting services that are covered by Medicaid. It depends on the state, it depends on the service, it depends on the model. It's sort of like all the caveats. And I do have a resource here, which I can drop in the chat afterwards too, from Georgetown, that sort of lays out the different mechanisms that states are using right now in this kind of patchwork system to cover home visiting services under their Medicaid program. So that is kind of the quick lay of the land of what Medicaid does on home visiting right now. Our roadmap, and this is a link up here, I think it looks like a link, but our roadmap was actually built for the District of Columbia's Medicaid program. And the thought behind this roadmap is that it was going to give states a framework. It was going to give them sort of a stepwise process to figure out, how do we start to cover home visiting services all the way up to, how do we really integrate this into a comprehensive maternal and health strategy across the state? So what's the low hanging fruit to cover home visiting services? And then what's the stuff that's really tough? And we kind of lay out a framework in order to do that. In the short term, the strategies are around quality metrics and sort of looking at your data and figuring out where gaps are, kind of that low hanging fruit. If you just know you want to do something on maternal and child health, you know you want to improve maternal and child health in some ways, what are kind of the initial steps you can take? And then more the long-term strategies of, let's focus on Medicaid as part of a sustainable funding model for evidence-based home visiting services. So as Jenny was saying, a lot of home visiting services are grant funded, and grant funding is great. And MIECHV is an incredible program, and it has allowed states to implement a variety of models in so many ways. But there's still reauthorization that has to happen. There's still a question mark. And for, programs, it's just not necessarily the longest term sustainable source. Now, I think MIECHV and Medicaid fund, sustainable Medicaid funding actually work together hand in hand. But if we could get more states to cover home visiting services in their Medicaid programs, it would just really sustain the programs longer. It would leave them less moving from grant to grant all the time and worried about how they're going to get funding. It would just make it a lot more sustainable and a lot more easier to plan around and be strategic and all of that stuff. So that's kind of why we are doing this. We want to make sure that there are these services available to women and children and families in the country. And Medicaid funding is one of the most sustainable ways in order to do that moving forward. Someone told me never to share a picture of papers and a slide deck, and I totally broke that rule here. But I just wanted to show you, as a part of this paper, we have an appendix where we sort of lay out what the different strategies are. And then we also cross-reference it with different examples from other states and what they have done. So for example here, and again, if you kind of look from left to right, it's kind of, easiest strategy to most difficult strategy, with quality being kind of the low hanging fruit and value-based purchasing being the higher hanging fruit, or the much tougher work that has to be done in a very comprehensive way. And then we tried to kind of outline different strategies that states have used within each of these buckets, because what my experience, the National Governors Association told me, is that states really like to copy each other. So they want to know who's done well and how can I sort of take that program and replicate what they've done and do that in my state. So there's a whole chart in here, and we also built this out not only in the general of like in generalities of what are these buckets and what are some state examples, but in the paper, we actually tailored it specifically to DC to say, here's what you're already doing in DC on these, and here's where you can actually go further. So trying to kind of give them that roadmap of how can we eventually cover home-based home visiting services more comprehensively in Medicaid. So I'm just going to lay out really quick the strategies that we identified, and then we can turn to a conversation. I mentioned that the first strategy is focusing on quality improvement efforts. And this is where I said, we encourage states to, pardon me, look at their Medicaid data, look at their public health data, figure out what's happening in maternal and child health outcomes and programs in their state right now, figure out where the gaps are, what's the data telling you, and then figure out how to build quality improvement plans around those gaps. So, perhaps giving MCOs some sort of quality benchmarks that they need to meet, or just saying that these are some of the quality measures we're going to be looking at in the next as we evaluate your work, that type of thing. Like, what are the quality metrics we can assign to this issue specifically so that it gets at those home visiting services. And then there are broader quality strategies, things that happen out of places like CMS, where there are quality plans that this can be built into as well. And we just are asking there to be some specificity around home visiting services and the outcomes for women and children and families that would really feed into those that would kind of like really get at those issues to be what is measured, at least to show if it's working or not working. So quality improvement efforts is sort of the low-hanging fruit step one or strategy one. The second strategy is around Medicaid fee schedules or state plans, and states, a big lever that states have is their own fee schedule and what they have in their state plan. So they can make changes to those state plans. I know they have to work with CMS on that, but Medicaid managed care organizations that are operating in a state, they have to sort of cover what's in these covered services, what's in the state plan, what's on the Medicaid fee schedule. So making those changes directly into the state's Medicaid plan and saying that you want to cover evidence-based home visiting services and writing that in there is another powerful way to do it, but not anything that's like pushing the envelope too far is probably how I would say that. And I will also say, which is sort of noted in here, because NFP is a nurse-based model, nurse-family partnership, it lends itself a little bit easier than some of the other models to getting Medicaid funding because it has kind of a clinician at the center of the model. Strategy 3 is utilizing MCO contract requirements. So here, states are regularly rebidding their Medicaid contracts, and there is an opportunity, especially when they're putting out those notice of funding opportunities and writing contracts, to really write in there some powerful requirements around what MCOs must cover and programs that they must cover. And you can almost write into the MCO contract anything that we're talking about today. And again, it would be like, do you want to write in a quality improvement effort, or do you want to require them to do some value-based purchasing? Like, you can write a lot of that stuff into the contract. So it's a big lever that states have in order to increase the services that are provided to people in the district or people in whatever state that they're working in. And then we also should say, because one of our other strategies is to go directly to the MCOs, at least in the district, and say, hey, you're already covering these women and we are providing them this service. And right now in the district, it's very grant funded, but maybe you, MCO, will see the benefit that this program is providing to the women you're already covering. And maybe you want to pay for it yourself. And you do have some discretionary dollars. You do have the ability through a variety of different mechanisms to pay for services. MCOs are able to do things that are outside of the state plan if they're sort of above and beyond. And this might be a service that actually they want to pay for on some level. So in the district, we kind of have an interesting bifurcated strategy where we're working with the Medicaid department to get coverage, but we're also thinking about how the MCOs could potentially cover this themselves as well. And then last is sort of the gold star. I'm not sure, the sort of highest hanging fruit. I don't know what the right metaphor is. Apologies, but adopt a value-based purchasing strategy. And this is really where you're tying, I have underlined here, tying perinatal health payments to health outcomes. So you're tying money to outcomes. You have both upside risk and downside risk, and you are really trying to use all of the leverage that you have to improve outcomes and shift away from that, traditional fee-for-service model where we're just sort of like paying for small things repeatedly or individual things repeatedly in a variety of different ways. This is a goal. The goal is to try to take a holistic approach and then also tie payments to those outcomes at the end of the day. I think that's it. Oh, what is it? I'm going to stop sharing, so I can drop a link to the paper. Okay, good. And I didn't freeze again. I can drop a link to the paper in here, but the thought behind this roadmap again is really that it was initially built for DC to try to help the Medicaid department here understand what their options were. And then hopefully it can be helpful to other states as they are thinking about also how do we pay for home visiting services moving forward.
Kelly, thank you for the wonderful presentation. I saw some chat around work in North Carolina and Illinois. So there's some good thought sharing there, and hopefully that roadmap is helpful as they are doing work in their states.
Awesome. I'm sorry, I totally can't monitor the chat while I'm talking, obviously. So that's super helpful.
Very, very impossible to do while you're sharing your screen, especially. And thank you for powering through a cold. Yes, children.
No problem. It's just the norm in my house with 2 little kids. So thank you for bearing with me.
I am sure that a lot of people on this call can empathize with that very well. So a similar question to one that we asked of Jenny, but how do you integrate trauma science into the model that you're speaking about? How do you think about that, especially understanding the intergenerational transmission that ACEs can have and that developmental adversity and trauma more broadly have as well?
I mean, that's a good question, obviously. And we are working on the NFP model. So I know Jenny said that it's thought of in the model development, and I am not the model expert also, obviously. But I think we like this strategy because it takes such a 2-generational approach. We love that it is not just serving, it's serving the dyad, and in a really comprehensive way. Jenny mentioned NFP starts before the 28th week of pregnancy. And I think it's like 2.5 years after birth, potentially. Jenny, is that right? I think it can go to just 2, but still, I mean, that is years of work together and years of someone, a home visitor getting to know a family and being able to do warm handoffs to other social services and trying to make those linkages. And they've been a huge part of everything that's happened on COVID. I just feel like that's why we are so passionate about a lot of, about these models that are taking this dyad approach, is that you can't really isolate, I think, either the parent or the child and really want to take a 2-generational approach. So that's what I'd say about the model. But I mean, it's also a good push that I should probably be thinking about that too as we do more work on this.
Beautiful. And as I said earlier, however we can help with that thinking, please let us know. We definitely have a specific interest as a group. Is there space for funding healthcare training?
Yeah, I'm wondering if we can get a little more. I just saw that. If Charlie, I don't know if you want to share either in the chat, which is totally fine, or is there more sort of, what do you mean when you say that?
Folks should feel free to come off mute. Charlie, go ahead.
Yeah, thank you. So I'm a medical student right now, and I'm thinking through the environment in which we learn and what gets emphasized in our training, and how to integrate ourselves more into the healthcare system to work kind of collaboratively with the methods of care. And so how can we bring this same awareness of the importance of this point in children's lives and mothers' lives, and really just health in general, to train healthcare providers to respond in this way to patients?
I mean, it's a great question. And I feel like there are so many needs around healthcare workforce in so many ways, obviously, right now. I'm definitely not an expert in medical education or medical training. So I feel like I don't have a great answer for you, except it's really needed. My hope is because this has been, a top of the fold prior to COVID, I should say, this has been a top of the fold like newspaper issue. It's starting in, 2015. I feel like we started to see information come out and some really powerful stories about Black maternal health in particular. I hope that gets the attention of people that are doing the educating to say, oh my gosh, they're like, the disparities are horrific and something needs to be done and we should integrate that into training. That's probably not the answer you're looking for, but I just think that hopefully that has gotten, I know it got onto governors' radars in a way that I had never seen prior to that. And so that was at least it made them take notice and say, hey, we need to do something about this. We're practically a third world country.
I'm just thinking of your strategy one in quality improvement and what could be implemented within hospitals in the form of like continuing education credits or really, GME, graduate medical education, or
yeah, that's true. Probably GME is a big lever there. Yep.
I would just like to piggyback onto that previous comment. I've been a nurse for 20 plus years, and until I became a foster parent, and until I worked in mental health, trauma was never talked about. It still is not where I live. It's a huge area because a lot of people within medicine do not hear about it at all, at least here in Iowa. And so I think once practitioners, providers hear about it, it makes a ton of sense. They wish they would have known. The problem is getting accurate, pertinent information to them because of the workforce issues, because of all of the things that are, on our backs because of COVID.
I mean, it's such a great point. Thank you for sharing. I wish I had a solution, but maybe CTIPP people do.
We will work on it. Esther, thank you for sharing that very, very much. The personal narrative is so powerful. Dan, I saw you came off mute.
Yeah, it's kind of follow up on that question for both Jenny and Kelly is, should there be a requirement that the nurses engaged in NFP receive training in trauma-informed science? Because it's not being taught in most nursing schools. Should that be a requirement before you're allowed to get engaged in the program?
That's a great question. I'm not sure exactly what, like the full training that our nurses go through. It's pretty rigorous and regimented in terms of, the training. And so I don't know if it's explicitly named as that, but my sense is that, there's huge components of it there. So that's something that I can look into, but it's not easy to change our training modules, as you might imagine, but I think that the general, notion of what you guys are talking about is certainly something that, we're trying to get, our nurses are coming to the families, trying to understand where they're at, what they've gone through. Kind of a centerpiece of our program is that the families, that mom or that parent is the expert in their own life. And so to really, build that trusting relationship with that parent, you have to hear them, you have to understand where they're coming from. And so we do talk about being a 2-generational approach. And so I think that's, a really important component.
Yeah, it'd be great. I'm sorry, Kelly. It'd be great if you could check into that, because I think Esther's point is something we hear over and over again. When professionals finally learn about trauma science, they kind of, the light bulb goes on and they say, I wish I'd known that a long time ago. So question is whether it ought to be more or something that's mandatory or highly recommended, rather than just counting on participants just stumbling on it, which seems to be what's happening now.
But not, I saw you had your hand up. Yeah, go ahead.
Yeah,
Oops, sorry.
so I'm newish I'm new to these calls, but I come from the perspective of I've spent years working in primary care and family medicine GME. I worked on advocacy and education. And one of the ways that we saw that shift further back into the pipeline, to respond also to Charlie's question, as somebody who is a learner in the healthcare professions, the way that we saw this shift and go further back into the training timing was, if we commented enough on a need and we heard from medical students or residents enough, a call for certain topic areas, subject areas, we would respond to AAFP's government relations team. We'd work with other advocacy groups, and we saw some of the program accreditation requirements change. If a program is required to include something in order to get their accreditation, that was for us the biggest carrot stick type of motivation that we could promote. And how the programs implement that is different, and what resources they use is different. But with national standards and promotion of these topic areas from organizations like AAFP, and Charlie, I don't know what specialty you're in, but in family medicine and primary care, we saw rules change over the past few years with consistent messaging, a push for certain requirements, and program accreditation requirements changing to include it. So we saw advocacy be included. And if AAFP put out their statement for trauma-informed policy and practice recently, if there's enough response to that, those rules and those accreditation rules could change if there's coordination between the accrediting bodies and those national organizations.
That's great.
That's really helpful.
Thank you. Manada, I know that Charlie put his group STAR, which, Charlie, if you want to speak to that for a second as well, just to let folks know, where we can also connect offline. And just to throw out an idea, Deb Berkey is putting together a community of practice or a community of learning for healthcare institutions as well. And so, Deb, I don't know if this is something that may resonate with an idea that you have as well, but Charlie, if you want to describe what STAR is, and then Dwana, we'll get to you next.
Yeah, thank you very much. STAR is the Student Task Force for ACEs and Resilience, and it is a group of health students and a few law students who are trying to come together and figure out how to advance really trauma-informed practices and policy. And we're kind of, yeah, that's enough now.
That's the elevator pitch, and we'll definitely hear more. Short elevator ride, like 2 or 3 floors. But thank you. Dwana, if you want to come off mute and ask your question or say your comment, please.
Sure. I can say that, hey, Jesse, here in New Jersey, that we have been working with trying to implement trauma-informed and the nurses' education component, because I think they've realized that that bedside manner isn't there. And so what we've been doing is trying to figure out a way, well, working with them to get that in the curriculum once they reach that component of medical school. But then we're also working with the universities and the nursing programs to somehow figure out how we can have even just the training alone to start to see how it resonates with them, to get that as part of their curriculum as well. So, there is room for adding it to the curriculum because it is such a missed area. And as we know, it will improve upon the connection between patient and practitioner. And then it allows them to dig a little bit deeper as to what really might be going on, what may be going on inside of them. So I can, once we get a little bit more traction, I have no problem sharing the work that we've been doing with Rutgers University in terms of getting trauma-informed information into our ACEs training, which is what we do within college curriculums. And we're working to also do it not only within the medical field, but more specifically within the social work programs, the psychology programs, as well as pedagogy, looking at universities taking it on so that these professionals, once they go out into the world in those professions, they have that skill set now. So if we get some information or traction, I will share it with Jesse and we'll just shoot it out to you.
Thank you, Dwana. Deb, I saw you came off mute. Do you want to share something as well?
I just want to reinforce this something in the chat box that Deborah Berkey put in, that she is heading a community of practice to promote trauma-informed programs in the healthcare industry. Deborah, do you want to just talk about that for a second and invite people to join?
Sure. Thank you, Jesse and Dan. I'm Deb Berkey. I am Director of Psychology Programs and the Center for Prevention Science at Wilmington University. And one of the things I've been working on over this past year is walking alongside one of the healthcare institutions locally who has committed to engaging in becoming a trauma-informed organization. And what we've been walking alongside for the first year, becoming trauma aware, wanting to move into trauma sensitive, responsive, and then informed. And part of what they have indicated is they would love to pull together a collaborative of individuals from other healthcare institutions who are also undergoing a trauma-informed journey or have undergone one, to kind of share tips and techniques and, you know, what's worked and what doesn't work and what's unique about a healthcare institution that's, say, different from a college and university. So I did put info in the chat with my name and email address. And if you know of anybody who's interested in joining, just reach out to me. I'd appreciate it. Also with Dewana too, I just kind of one more pitch. There is a group of colleges and universities who indicated an interest in trauma-informed work on campuses. And we have sponsored by CTIPP, and we do have a listserv, and we meet once a month via Zoom. And so I'll put my name again in the chat with that message and just say, email me, and then I can connect you with the individuals who organize that meeting. So thanks, Jesse and Dan.
Thank you, Deb. Yeah, CURE is fantastic.
I was at the last session. It really is a great group of folks doing great work.
So folks who are interested in that, we're the community of learners. Feel free to take a look in the chat box. Lots going on there. Kelly and Jenny, a question for both of you. From your, Jenny, federal policy experience, and Kelly, from your state policy experience, one thing that I'm curious about is how we sort of work along all systems and levels of government, you know, state, federal, local, tribal. And so are there different ways that we advocate or talk about different things to sort of support the same program at the various levels? Based on your presentations, I think that there are, but if you're able to sort of synthesize that for us, I think that that could be helpful. I also don't know if that question was overly clear. So.
I mean, I can talk a bit about like MIECHV and how that looks. So, you know, at the federal level, obviously that's, you know, where the money's coming from. That's where the large, you know, statute set. That's also where, you know, the regulatory, you know, changes are happening, you know, within HRSA. But at the state level is where the implementation is occurring. And so for us, we really have a lot of connection that we have to constantly do between that federal and state level. You know, this state has flexibility in how they're implementing MIECHV. They obviously, you know, have a lot of leeway on where they're implementing, you know, MIECHV programs, which MIECHV programs. So while I'm advocating, you know, for the dollars at the federal level, we have folks, you know, at the National Service Office who are advocating then for those dollars to get spent on NFP programs, you know, particular places, you know, at a community level. So and then when I'm talking to policymakers, you know, in DC, they want to know what's happening, you know, at that local or state level. And so being able to know what's happening on the ground, how it's being implemented, what the challenges are, what the opportunities are, and then carrying that back to the federal level helps strengthen the advocacy there. So not every program always has kind of that direct federal to state connection, but particularly a program like MIECHV, there's a lot of it. And it, you know, I mean, we see that over lots of different funding streams, but you know, you've got the passage of the policy, and then you've got the implementation of the policy, and they're very connected, but you know, very different kind of areas you're focused on within those.
And I would chime in and say, this is an opportunity for me to get on just a tiny little soapbox. But first, we are also taking a both and approach. We're actually going to be hopefully advocating for a Medicaid home visiting benefit at the federal level, because then that would cover all states. But we also realize that that's probably a tall order. Like, see what Congress can do right now. It's nothing. So we also are focusing at the state level. And I think my goal with this actually, because I know this, I feel like this will speak to you all, because in states, and my experience in states is like everything is so siloed. Home visiting has historically been seen as a maternal and child health grant funded program. It has not really on the radar of Medicaid people. So even for advocates in states, a Medicaid advocate or a healthcare with a Medicaid focus advocate, those types of statewide or advocacy organizations, they do not talk about home visiting as something to put on their like Medicaid advocacy agenda. And I would love to change that, because otherwise these programs are serving the same women that are covered by Medicaid. It like frustrates me to no end that home visiting isn't on the radar of Medicaid advocates. It's not on the radar of child welfare advocates. It's like in its own little niche in kind of maternal child health groups, in public health spaces more generally. And I would love to break down the barriers and actually get this on like all the advocates' agendas, so that then state legislators are like, oh, we heard that from the child welfare folks. Oh, we heard that from the Medicaid folks. Oh, and the MCA, the public health people, they're saying the same thing. And like it just, there are just some silos that make it really challenging to do that. But I would say that's my message to advocates is like, let's try to get these programs that can work in an intersectional way onto others' agendas so that it can be pushed from a variety of places, if that makes sense.
Absolutely. We definitely want to get rid of silos, so want to support that. Esther, I saw your question, but want to kick it over to Duana, who I think has an enthusiastic response to what Kelly just offered.
When I started out with DCF, I started out in the field as a CPS worker. And one service that the county that I started in had what they call homemaker services. And so, Kelly, when I hear you talk about intersectionality, I'm thinking maybe a little head, or maybe it's called foresight. If you had what they had, the homemaker service, that person went in with that parent, that young adult, more or less, and helped them create a routine within that household to find that balance. And I think when you do that, especially if that person is trauma-informed, aware, and responsive, for me in CPS, well, at the time, you prevent that call from happening also, because you've become aware of some things, assessed some things, provided some service or some things that that parent probably wasn't aware of. I choose to believe that's connected to those generational cases that CPS offices can get. But when you have that homemaker worker go into that house trained in trauma responsiveness, I think it will create a different experience, not only for that mother's life, that child's life. And then I think you will start to dial back those generational cases that CPS offices can get, because then you can start to deal with some of the generational trauma, because you now stop something in this track from simple as having a homemaker service available to a young or even, an older mother who has never parented or may have other children in the home. That's a skill set. It's not something that women are organically born with. Again, never knowing the systemic issues happening on the outside. So that's why I was like, oh, you have my full support with that, because when I went to another county to work and they didn't have it, I saw how those households struggled, and then how they had more generational cases in that county. And it was from something simple as a homemaker service. And so any way that I can share my insight into or experience with that, you can feel free to contact me about that. And I would love for it to be covered by Medicaid, because it is essential. You can't talk about child infant mortality rate, especially in Black and brown households where the systemic issues are so rich, and you not give them a service that could begin to cut it down at the root, which is at the birth of that newborn child. So I'm here to support and be of advice, whatever you need.
Thank you for that offer, and so beautifully said. Like it's also true.
Juana, I'm happy to connect you and Kelly offline to continue having the conversation.
Thanks.
Yeah, thank you. Esther, I saw your question in the chat. Have you ever heard of Iowa ACEs 360? Because go ahead, Esther.
Yeah, I'm a committee member.
Fantastic. So just wanted to make sure you were connected there. Linda, I know that you're not actively off mute, but I saw your comment in the chat earlier about doing this in a red state. Linda Manaw works in Oklahoma and has done a ton to help promote ACEs, trauma-informed awareness in Oklahoma. Linda, see you on video. If you can respond to that question a bit, how, I'll get the question up so that way Any tips on where to start in a state that thinks ACEs are not real and are resistant to advocacy in this area?
Well, we don't really have that problem. As a matter of fact, I'm multitasking and I just pulled up a bill where we apparently have a senator who has put through a bill, and we've never even talked with her, and this is to require ACEs screening. Well, not to require the healthcare authority to pay for it, do it in pediatrician's office and refer for appropriate services. Of course, we know that that's really not necessarily the appropriate use of the ACEs questionnaire. So I'm, sometimes we rush too far into it without knowing what we're getting into. That concerns me. But no, the problem we have is, well, our governor said the other day that God gave children to parents because the parents know what to do best. And so in other words, let them alone, let them parent. Nobody needs help. And so, we just don't focus like we should on vulnerable children and families. Getting that attention, helping them understand that that's a long-term economic decision not to invest in your youngest children, your youngest citizens. Not sure if I'm answering the question, Jesse, but we just, we put together an early childhood legislative caucus and, kind of went office to office and tried to find people that were, would wanted to be a part of building a coalition for kids. And we just keep working at it. We just, we put the data in front of them. We talk about evidence-based programs. Don't wholesale cut, 10% across the board of everything when you cut a budget. Look at the programs that are working and don't cut those. It's sometimes it's one step forward and two steps back. It's it's kind of discouraging sometimes, but we do have a good, a small group of legislators that get it. And I think, I've come to the conclusion that we need to better inform all the voters so that when somebody comes to their door and asks for their vote, that they start talking about these issues. And how would you vote on this? How would you vote on that? These are my priorities.
Thank you. Yeah, I know that I put you on the spot a little bit there. I just know that you've also been doing this for a long time.
Yeah, always happy to learn from other people too.
Mm-hmm. So yeah, I know it's 3:30. So Jenny and Kelly, thank you so much for the presentations. We will be following up with more information. To Linda's point there, I think that this is a long game, right? Not with MIECHV, that is a short game. Like Jenny was saying, we've got to do that this year, hopefully sooner, and get that reauthorization level up. Promoting trauma-informed policies and practices. That's all about developing relationships. And so our work as advocates, developing those relationships, promoting ongoing calls to action, raising awareness, and acting in a trauma-informed manner, frankly, with staffer and elected officials who oftentimes don't get that, is so important. Next month, we're going to be having presentations from North Carolina. So invite everybody back to next month's CTIPP CAN call. And again, please join the Building the Movement workshop series this coming Friday for a transformative justice workshop and the panel on faith-based communities. Thank you all so much for being with us. And Kelly and Jenny, again, thank you for the valuable information.
Thanks for having me. Nice to meet everybody.
Feel better.
Mhm.